Good day. Topic of our lecture: tooth fractures and traumatic dental alveolar injuries. Uh, Etiology, causes and contributing factors are unexpectedly biting on hard objects, for example, pips, stones, tooth wear, excessive erosion, caries, cavity preparation, and endodontic treatment, and of course, bruxism. Changes in the oral temperature can lead to cracking of the enamel of the incisors due to differences in the expansion coefficient of enamel and dentine. Little dentine remaining after cavity preparation increases the probability of a crack. The sharp internal line angles in the preparation promote stress, concentration, and related to masticatory forces, which initiated and propagated cracks. Then, other causes, it is non-positively fitting cast restoration that have been forced into place, and excessive hydraulic forces during lutein, or, for example, placement of parapulpal pins close to the enamel, and restoration with steep occlusal stops that result in the increase in the horizontal component of masticatory forces. Of course, you need to know about using of high condensation pressure when carrying out an amalgam restoration, and moisture contamination during condensation of the pure quality amalgam. Dealing with cases of suspected abuse. Um, Physical abuse may cause oral injury, yes, and sometimes uh, orofacial blows, such as fractured with the use of forceps, oral electrical torture cause all kids of facial and oral injuries. So many causes of trauma and teeth injuries. Etiology we speak, yes, it is biting of hard object, tooth wear, excessive erosion, caries, cavity preparation, endodontic treatment, and of course bruxism. The frequency of injuries in children, injury of temporary teeth 11 to 30%, injury of permanent teeth from 5 to 29%, and boys have injuries 2 times more. Age 2-3 years old, and 8-10 years old. Localization, it is upper anterior teeth. Then, what we need to know from our patient. Questions to ask. First of all, when did the injury happen? How did the injury happen? Were there any other damage? When and what first aid was provided? Have there been other tooth injuries in the past? And is there regular immunization? These questions. And examination, full body examination, then expanding the boundaries of the survey in oral cavity, then full diagnosis assessment of the degree of damage, hard fabrics, pulp, periodontal, alveolar bone, and gums. Then medical history, damage to oral cavity and gums. It is checking the contour of the gingival margin, rupture of the gingival papilla, vertical gap of crown and frenulum rupture, a lip perforation maybe can be, and hematoma of the bottom of the oral cavity, and palpation of the alveolar part. Then inspection of injury, hard tissues damage. Please look, it is tooth fracture, fracture crown root, root fracture. So you should know localization of this injury, type, degree, displacement of coronary fragment, so localization of this fracture line, and this localization of fracture line only on tooth or maybe to the alveolar bone. Then medical history, X-ray. Yes, I'm sorry for mistake. So here is different types of X-ray. Medical history, injury inspection, so pulp exposure or tooth discoloration, you can see. Then medical history, pulp assessment test. It is temperature sensitivity, for example, cold test. EOD, it is electrodontal diagnosis. Then temperature sensitivity with a warm test, and method of trans elimination. Then periodontal damage, it is concussion, tooth displacement, and tooth mobility. Percussion maybe. Then tooth condition before injury, so unfinished root formation, for example, pulp necrosis and periodontal disease in the past, crown coating, caries, and occlusion, problem with occlusion. Then temporary tooth injuries and a clinic. Clinic, we know anamnesis, damage, complaints, yes, blast and mobility, occlusal disorders, percussion, X-ray, of course, and anamnesis, topical bruise, light blow, damage, periodontal problems, periodontal edema. Complaints, it is pain, bias no, mobility normal, occlusal disorders no, percussion painful, the sound is normal, and X-ray no change. Subluxation, please look. Subluxation of temporary teeth. Treatment. Sparing diet, 1 week, very necessarily. Recommendation to parents, and individualization of observation. Of course, endodontic treatment if pulp viability has not recovered within 6-8 weeks. And Doctors Spiridonova and Leporskaya additionally recommend tooth shutdown from occlusion, grinding of the antagonist tooth or a special capper, a temporary splinting, OHA therapy, ionophoresis with analgesics on bruised area. So this clinic of impacted dislocation, so analysis, damage, and mobility occlusal violation and percussion is painful. Intrusion treatment, observation of course, and a removal in case of injury, the germ of a permanent tooth. Um, Lateral dislocation of the tooth. So, vertical crown root infraction. The probability that cracks extend beyond the epithelial attachment increases the more distally the tooth is situated. So crack progression into the root may split the tooth. The shape, size, the material of canal posts, to determine success or failure. Tapering canal posts, large diameters, and use of the large torsion force while inserting threaded posts increase the risk of longitudinal infraction and fractures. So diagnosis and appearance. Diagnosing a crack may be difficult. Cracked vital teeth are rarely, about 15%, painful, but even they often remain undetected or misdiagnosed, as for example sinusitis or ear pain. A crack in the enamel can't cause pain, but deeper cracks open minutely under pressure, and when they close after cessation of the pressure, the consequent movement of the fluid in the dentinal tubules can cause pain. Pain elicited by chewing are called stimuli, and sweet and acidic stimuli may represent a dentinal crack. So it is green stick fracture. Dentin caries may develop underneath sound enamel when plaque simulated is in deep cracks. So, tooth by tooth information may be gained with the use of occlusal biting devices or with the application of some polymerizing composite on the suspected cusp. Cracks are often difficult to observe, including on radiographs, unless they run parallel on the X-rays. Then prevention and treatment. This cavity preparation must be kept small and shallow, and internal line angles should not be sharp. Still, occlusal cuspal slopes must be avoided during carving or the restoration. When a crack is present, grinding of the cusp is an acceptable provisional measure. Despite this, however, the foot bolus may load the tooth unfavorably, and a temporary solution to avoid crack propagation, fracture, and pulpitis is fighting the stainless steel band, which also help elevate the pain. Endodontic excess preparation increase cuspal fracture, and which may require partial coverage crowns rather than composite restoration. The adgazer restoration approach is non-vital. Premolars is promising. Spontaneous tooth fracture is separation and loss of the tooth segment due to loading with masticatory forces of parafunctions. tooth fractures have the same causes as cracks, or cracks may propagate and become a fracture. Such fractures sometimes manifest when chewing soft food, for example, because the fractured part of the tooth becomes incorporated in the food bolus. A cusp or wall of the restoration may be lost after removal of a filling. A horizontal fracture is often restorable. A vertical fracture poses a serious problem and may require extraction. Then cervical abfraction, physical stress induced or non-carious cervical lesion. Cervical abfraction lesions are small V-shaped defects with sharp margins that are found mainly of the buccal enamel surface of the permanent teeth, and which may primarily be caused by occlusal forces. So it is a lateral dislocation. Then treatment, it is removal, finger reboning, and splinting. So treatment of hemorrhage and lateral dislocation. Please look trauma, the second step, and result. Fractures of temporary teeth, so without pulp exposure and with pulp damage. Crown root fracture. Fractures of temporary teeth, look please. Two parts of the root. The consequence of injuries of temporary teeth from the permanent teeth, it is enamel hyperplasia, malformation of the crown and roots, a complete underdevelopment of the primordium, then late teething, a change of position, rudimentary teeth, and follicular cyst development. The consequence of injuries. Please look this problem with enamel. On the part of temporary teeth, color change, pulp necrosis, root resorption, ankylosis, a change of position, and root canal obliteration. It is the part of temporary teeth. Permanent injury, so survey, it is electrodontal diagnosis, X-ray, and treatment, sparing mode, and crack coating with fluoride varnish or gel. You can use 5 or 7 procedures. It's enough. So in this situation, you should doing coating and restoration. Then medical examination, 1-2 weeks after 1 to 1.1 months, and every 6 months until the end of the root formation. We need medical examination, doing X-rays and electrodontal diagnosis 3-12 months for understanding pulp is vital or not, and X-ray every 12 months. Then permanent injury, of course, temperature tests, electrodontal diagnosis, and X-ray. Uncomplicated tooth crown fracture, enamel cleavage treatment, smoothing, chip line coating with fluorine varnish, and composite recovery, restoration. Enamel and dentine fracture treatment, It is overlap. It is glass ionomer cement. I'm sorry, seats. Glass ionomer cement, overlap composite, composite crown restoration, fragmentation fixation, and in the case of close proximity of the pulp, we use a calcium containing pad and a pulpotomy of Quebec. It is special method. Then fragmentation fixation. Look, it is fragment of enamel, but without the pulp, and we can to fixate this fragment. Then enamel and dentin fracture. Pulpotomy of Quebec. It is special method. First step, local anesthesia, isolation with rubber dam or cover dam, pulp amputation with sterile burn and and stop bleeding. Normally 2 minutes you can stop bleeding. If bleeding can't stop, it is you should doing endodontic treatment in this situation. Anchored calcium hydroxide, hardened calcium hydroxide, and seal with glass ionomers or with composite. And dispensary observation and permanent root canal obstruction. Look, please, it is bleeding pulp. It is stop bleeding. If you see this situation, you can take calcium hydroxide here and doing restoration. After 1 year, it is resolved after pulpotomy. Apexification technique, of course, local anesthesia, rubber dam, mechanical cleaning of the canal, not reaching to 1 or sometimes 2 millimeters to the apex. Then drug treatment of the canal. You can use hypochlorite natrium or chlorhexidine. And ethylenediamine tetraphosphoric acid and citric acid. Then anchored calcium hydroxide, hardening calcium hydroxide, seal with glass ionomer cement or with composite. Dispensary observation and permanent root canal obstruction. Apexification technique. Look, it's very wide apex. And after treatment, apexification. Signs of pulp necrosis, it is first of all tooth discoloration and negative cold test. Periapical changes can be, of course, pain, excessive mobility, swelling of the gums, and lack of electrosensitivity. Pulp necrosis is recognized if after 12 months there are no signs of fracture healing and inflammatory resorption in the fracture area. So pulp obliteration within 1-2 years can be in 33 or 73 to 86%. So if you need in the future doing endodontic treatment, it will be a big problem because we will have root obliteration. Conditions necessary for fracture healing, it is Kronenfeld. Accurate reposition of ensure close contact of both fragments, and then strong immobilization of these fragments where necessarily step. No pulp infection, so you should working with sterile bores and instruments, and good patient immunity. So vertical crown root infraction. Please look on the picture. Here you can see crown and root injury. And so the diagnosis, dentine caries may develop underneath sound enamel when plaque accumulated in deep cracks, and cracks extended to the pulp lead to pulpitis. Then bacteria colonize subgingivally and penetrate the cracks, giving rise to small, deep periodontal defects that appear on X-rays and diffuse radiolucences. Then spontaneous fracture is separation and loss of the tooth segment due to loading with masticatory forces or parafunctions. Then cervical abfraction, we stop on this type of injuries. So the initial phase of development of abfraction lesion may comprise loss of cervical dentine and undermining of the enamel. The lesions are characteristically wedge-shaped and located at sites of tensile stress concentration. Erosion, in contrast, results is more disc-shaped lesions. Please look, it is abfraction. And abfraction, what about prevent and treatment? Occlusion adjustments reduce cervical stress. Their tensile stresses may lead to debonding and loss of cervical restoration, for which reason macrofilled composites then flex with the tooth are preferred to stiffer ones, and a thick layer of the flexible liner and mechanical retention are recommended. Abrasive or erosive lesions are preferably restored with composite resistance to wear. Sometimes dentists use glass ionomer cement, special, for example, special material for abfraction. It is Fuji 2LC. It is very good material for this situation. And dentists should consider erosion as a diagnosis and treatment for non-carious cervical lesions. But abfraction must be kept in mind as a primary cause. Then, 5 main types of tooth fractures. Look, please. In this case and in this case, you need extract tooth. Crown infraction. Traumatic crown infraction is an incomplete fracture in the enamel and or dentin caused by the external force without separation of the segments. and uncomplicated um, crown infection, traumatic crown. Oh, sorry, I see. I tell you about this and treatment. Their prognosis is usually uh, favorable, and infected anterior teeth does not need treatment unless the tooth is heavily loaded functionally, in which case grinding is indicated. The crack may be sealed with an unfilled composite to prevent staining. Pulpitis develops in 0 to 3.5% of cases. A part of the tooth may fracture between dental follow-ups. Deciduous teeth, crown in fraction of deciduous teeth are rare, and a gray discoloration that becomes yellow in 75% of cases is indicative of pulp obliteration, and a gray-blue or black discoloration is due to pulp necrosis. With respect to the sequelae of the injury, it does not matter whether dark discolored deciduous teeth are endodontically treated or not. So, traumatic injuries to the teeth in children younger than 4 years often may only slightly intrude their tooth. Deciduous teeth, 75% of cases, yes. And uncomplicated crown fractures. So pain occurs when the dentin is exposed, and temperature changes, sweet, acidic stimuli, and touching. Pain because the white dental tubules are suddenly exposed, and when the periodontium is injured. So, deciduous teeth, the treatment of uncomplicated fracture, about 80% may be limited to smoothing of sharp edges or application of a glass ionomer cement on exposed dentine. Most crown fractures are uncomplicated. Often the enamel alone is fractured, and inspection, palpation, and X-ray may reveal embedded tooth fragments in the soft tissues, and which, if not removed, can cause infection and malformation, for example, of the lips. Late detection may necessitate removal via an extraoral approach. And treatment and prognosis. So when dentine is exposed, bacterial ingress and their toxins endanger the pulp. So provisional protection can be achieved by application of a varnish or glass ionomer cement due to lack of time. It is emergency appointment or patient cooperation. So the tooth is restored with composite, but when only the enamel has fractured, just smoothing of the sharp edges may suffice. Then complicated crown fracture. The treatment is dictated by the period of contamination of the exposed pulp, and retention of the wound dressing, and the development stage of the root. The treatment options are direct pulp capping or partial vital amputation and extirpation and eventually apexification. So the pulp is extirpated when the root is fully developed. If not, extirpation is the last desirable option. A vital pulp is the best condition for ongoing root development. Next, deciduous teas. A crown root. A necrotic pulp is an immature tooth requires extirpation and epexification with calcium hydroxide. The calcium hydroxide should be replenished every 3 months to induce the formation of the apical barrier and to enable condensation of gutta percha. So insertion of calcium hydroxide, is in the first endodontic session leads to narrowing of the open apex within 9 months. If the root canal is filled with calcium hydroxide in the second session, it can take up to 20 months. It is special protocol of your steps of your treatment. Then addition of the disinfectant, all the calcium hydroxide filling has been found to promote apical closure, but is not indicated. And after apexification with calcium hydroxide, the fracture resistance of the root is halved within 1 year. Then crown root fracture. In maxillary premolars that are injured via a blow of the mandible, there is usually a loss of the buccal cusp. And the gingival fibers may hold the fracture segments in situ, because of which the fracture may go unattized. However, under application of pressure, the tooth fragments will separate, and the periodontium is also injured in these cases. Treatment and prognosis in this situation. Extraction must be considered when the required crown preparation for the restoration will damage the adjacent teeth, or the fracture extends more than from 3 to 4 millimeters below the gingival attachment. A fracture ending below the attachment may require gingivoplasty to ensure periodontally acceptable restoration. When the fracture extends deep below the epithelial attachment, the crown and root ratio must be minimally from 1 to 1, and to warrant restoring the tooth. Orthodontic or surgical extraction can be used to bring the fracture sites to supragingival levels, where a ferrule of from 2 to 3 millimeters can be preparated. Deciduous teeth. And please look about anterior teeth. A large overbite is an indication for orthodontic closure of the extraction space, and post-treatment complications include loss of bone and gingival retraction around the adjacent teeth. When a lateral incisors is used to replace a lost central, this leads to any asymmetry. Um, so, tooth replacement with a Maryland bridge, for example, or an implant is another option. Then, auto-transplantation of preferably or a mandibular first premolar, including Hertwig Talus shell into the place of the lost maxillary central incisor, seems the best solution when orthodontic extraction therapy is indicated. And posterior teeth, crown root fracture in posterior teeth are often uncomplicated. In most cases, crown preparation is possible eventually after gingivoplasty and osteectomy or orthodontic extraction. If the fracture is complicated, endodontic treatment is performed along with epixification in the case of an immature root. Vertical crown root fracture. A traumatic vertical crown root fracture involves splitting of a tooth by an external force over its entire length. Two-thirds of the affected teeth were maxillary premolars, one-third were mandibular molars, nasal roots, and 10% were mandibular premolars. 57% patient had chronic symptoms and 31% had acute symptoms. Bone resorption was present, the majority of lesion being V-shaped and often narrow. Roots with deeper growth of the surfaces are especially more at risk. Root fracture. As a fracture plane is seldom parallel of the X-rays, and the fracture appears ellipsoid in shape of radiographs, giving the impression of tooth fracture. So then healing. Here is 4 types. Type 1, disformation of osteodontine union of the fragments within from 2 to 3 months by deposition of dentine covered by cementum. Type 2, healing. It is formation of connective tissue. When the tooth fragments are dislocated, periodontal cells dominate the healing process. A connective tissue bridge is formed before the severed or stretched pulp can react. Type 3, it is interposition of bone and corrective tissue. And type 4, it is interposition of granulation tissue. Subluxation is a traumatic periodontal injury with tooth mobility, but without tooth displacement. Percussion and biting are painful. The percussion sound will be dull. The damage consists of hemorrhages, edema, and torn periodontal fibers, followed by transient external root resorption. Trauma associated with a tooth movement may damage the periodontal tissues, and complication are pulp obliteration or necrosis, resorption, and damage to the succedental teeth. The periodontal ligament has considerable potential for repair. Treatment in this way, is grinding of the antagonist teeth is recommended, and if several teeth are involved, semi-rigid splinting should be done for 1 to 2 weeks, and the gingival sulcus may bleed. And luxation, yes. Intrusion is traumatic partial or total displacement of the root of the tooth into the jaw. X-rays show the perpendicular place to be absent and aid in determining the position of the injured tooth. The displacement may be considerable. There is some report of root apex protruding into the nasal cavity. The periodontal membrane and blood vessels are severely crushed. Compression of the blood vessels causes ischemia and increasing the likelihood or root resorption. And treatment, intracted teeth have been repositioned and splinted. After the therapy, pulp laser Doppler flowmetry and dropped to almost nil in 36 weeks in one study. Prevention. Besides learning appropriate sporting techniques, using mouth and face guards, helmets, seat belts, protective clothing, prevention of dental injuries is often impossible. Mouth or face guards considerably decrease the risk of dental trauma, jaw and brain concussion through shock absorption of blows in the chin. Then splints. Should stabilize the tooth in its normal position during the immobilization period. Should be made directly at the chair side. Should not damage other teeth during insertion or removal. Must not exert orthodontic or traumatic forces. Must not promote gingivitis or caries. Must not affect the occlusion or articulation. Should not interfere with sensibility tests and endodontic treatment. Should preferably be cosmetically acceptable. Must allow some movement in case of periodontal trauma, although soft fractures require rigid splinting and protect the developing callus. Fracture of the root and treatment, local anesthesia, reposition of root fragments, hard splinting for 3 months, tooth extraction from occlusion, endodontic treatment immediately after injury is contraindicated, sparing diet, oral care types, and antibiotics therapy. About antibiotics, prophylactic antibiotics are are advised when bacteremia is likely and are definitely administered to patient with heart conditions and a medium to a high end risk of endocarditis after replantation. Please remember, antibiotics may prevent inflammatory root resorption, although in a study in rats, they were ineffective after delayed replantation. Um, in case of dry stored abused teeth and teeth with injured periodontal ligament and infected pulp, systemic tetracycline is preferred because of its antiresorptive actions. Soaking in doxycycline promotes the rate of revascularization and continuing of root development. In imaged teeth kept dry for 5 minutes before implantation, pulp revascularization occurred in 91% when coated with minocycline. 73%, when soaked in doxycycline, and 33% when soaked in saline. Treatment. Where early treatment is instituted, the wound is cleaned and the shear repositioned in situation for 4 and 5 days. When the treatment is delayed, granulation tissue develops. The management then focused on plaque control with chlorhexidine rinses, and healing is very slow and may be unsatisfactory. Fracture of root. Splinting the heart for 3 months. It is different doctors, Andreasen, then Whitner, Herfurth, and 6-8 weeks it is Kisalnikova. Bruce subluxation and subluxation. Control visit after 1, 3, and 6 months, and after a year for 4 years. Control tooth colors, tooth mobility, electrodontal diagnosis, and X-ray. Subluxation for a caused pulp necrosis in 3 to 6%. Tooth cavity obliteration 11% when unformed roots, and 8% formed roots. X-rays and results. Please look. Tooth cavity obliteration. A mouth guard designed of the maxilla should comply with the following requirements. It should cover the incisal edge of anterior teeth, the occlusal surfaces of the premolars and the buccal gingiva, up to 3 mm from the mucobuccal fold, without interfering with the movement of frenal attachments. Then it should be 2 mm thick. It should cover 5-6 millimeters of the palatal mucosa and have a palatal thickness of 2 millimeters with a thin ending. And it should be 3-4 millimeters thick incisally. We speak about preventing about all injuries in oral cavity. Please write conspect and send your conspect in Google Class, and then you will have a mark. Thank you for attention. Goodbye.